We'll welcome everybody to the January National Newborn Screening Pilot Monthly Webinar. I know we'll give folks a few minutes to join, but we do have a packed agenda, so we'll work on the intro slides. So just a reminder to mute yourself while others are speaking. Use the chat window to ask questions. Jennifer and I and the rest of the MBSTRN team will keep track of any questions you have during the talks, and then we'll have some time for some questions and answers after our speakers are finished. And we're really excited today to welcome Dr. Ingrid Holm and Dr. Wendy Chung. They're both going to give us a little bit of an update on efforts that they are conducting at their institutions to help advance our understanding of the use of genomics in the neonatal period. And so you might wonder, why is MBSTRN hosting this type of talks during our monthly pilot webinar? We know that APHL meeting, genomics is on everybody's mind in the newborn screening community. So I just wanted to remind you that as MBSTRN begins its 15th year, our work is to support researchers as they design, conduct, share, and disseminate efforts to think about the use of genomics, not only for screening neonatal disease, but also for diagnosis and potentially to design treatments and interventions and monitor health outcomes longitudinally. We also help researchers create question and answer sets to support long-term follow-up efforts. And we've got a bioethics and legal work group, as well as a tool on our website to help researchers think about including ethical, legal, and social implications issues as they plan their newborn screening related research. We also, as we're doing today, like to share across the newborn screening community about ongoing efforts to explore the use of genomics. And so we're really excited and delighted to welcome our presenters today. And so we're going to begin with Dr. Ingrid Holm, and you're all have heard from Dr. Holm during MBSTRN's MBS Research Summit, as well as our network meeting. But just a reminder that Dr. Holm is a pediatric geneticist and endocrinologist with a broad area of research. She was one of the active leads of BabySeq 1. I'm not sure, Ingrid, if you call it number 1, but we're going to hear mostly today about a recap of BabySeq and what they did in that project and how it is informing a new effort that they're undertaking called BabySeq 2. So with that, Ingrid, I'm going to stop sharing my screen and let you bring up your slides so that you can run them.
Sounds good. And thanks for the introduction. All right. And can people see my screen here?
Yep.
Okay. And is it in the correct mode?
Looks like it's in a good mode.
It looks like it's a good mode. Okay, so I'm going to talk about, so this talk is entitled BabySeq 2, which is implementation of whole genome sequencing and screening a diverse cohort. And I'm a co-PI on this with Robert Green. I'm going to start off by talking about just a little bit about the limitations of newborn screening and how that's informed what we do. So as you know, some of the limitation of newborn screening is that as kind of gene therapies are being developed all the time, it's still a very slow process to add new conditions to the RUSP. And essentially thousands of other conditions could be screened for simultaneously if we used genome sequencing. And this is just to make the point here that rare diseases are rare, but altogether they're actually not entirely that rare. And in fact, there's a number of diseases, it just kind of summarizes some of them, where there are treatments that would be available in childhood for a genetic condition. So the purpose of BabySeq, the first BabySeq project, was to examine the utility and impact of genomic sequencing in newborns. So we looked at the medical impact and the individual public health, behavioral impact on physicians and parents, and the economic impacts. And really the goal was to explore how genome sequencing could be incorporated into newborn screening. Sorry, there we go. So the BabySeq was a randomized controlled trial in healthy and sick individuals. We had a cohort of newborns from the ICUs, and we had a cohort of healthy newborns. And we essentially either had come standard of care or standard of care plus whole genome sequencing. The study staff disclosed the results to the parents. The results were sent to their pediatricians, and the neonatologist, in the case of the NICU for the newborns, were placed in the medical record. And then we looked at infant, parent, and physician outcomes. And so the return results in BabySeq was quite broad. So if you just think about the kind of the core conditions on the RUSP or the conditions on the ACMG list, which are very limited, BabySeq is really looking or returning the results for over 1,000 conditions. I've tried to kind of summarize here a little bit of how we curated the list. So this is work that Dr. Bishoy did as part of our project. And so essentially the Laboratory for Molecular Medicine and Broad Institute was responsible for kind of curating the results. And so we looked at gene disease validity. So we looked at genes with strong and definitive evidence for relationship to a disease, genes that are highly penetrant in childhood onset, and then genes in which there was maybe not as the disease may not happen in childhood, but it was highly actionable in childhood. And so when that was all done, there were about 1,000 genes that met our criteria for reporting of results. And so we had what we called the newborn genome sequencing report. And it should just say that the fact that we had about 1,000 genes that we analyzed sets this study apart from other newborn sequencing studies that have just a list of maybe a more limited list of only actionable genes. Our list was really much broader than that. So again, childhood onset, strong evidence, and high penetrance. We returned results for genes with moderate evidence and penetrance, but were actionable in childhood. We had at the end a couple of very highly actionable adult onset conditions, but in general did not return result onset conditions. And we used the ACMG AMP criteria for pathogenicity and really stuck with the pathogenic and likely pathogenic variants. If a child had a particular condition and we wanted to look into more depth into the genome, we did return VUSs for those indication-based reports. So for example, if his child had a seizure and we're looking for genetic contributions to a seizure disorder. And then we did surveys to assess the impact on providers and parent behaviors. So the top part there is a parent surveys on the baseline, post-disclosure, 3 months post-disclosure, and 10 months later. And then we had a baseline survey for physicians who had a patient that was in the study, and then looked at a post-disclosure survey and an end-of-study survey for those providers. And in parents, we looked at psychological impact, the effects on the parents' relationship with each other, as well as their relationships with their child. So in terms of recruitment, we approached over 3,000 parents, and upon initial approach, most of them declined. So 84% of people basically said, we're not interested in hearing about the study. Among those who did actually attend a enrollment session, which would end up being about 10%, 67% of them enrolled in the study. So the bottom line is people, they declined. It was really in the beginning. We don't want to hear about this, but once they heard about it, most people did enroll. And these are just some reasons for why parents didn't enroll. So some just said they weren't interested in research. And if we got some specific reasons, you can see some of them here. That they were either overwhelmed, uncomfortable with sequencing, privacy discrimination, and mostly it was really study the design and logistics. So remember, this was a randomized controlled trial, so half of the families were not going to get sequencing, and there were a number of surveys that were involved. So we had 159 babies in the newborn sequencing arms, 31 of the NICU infants, and 128 well babies. And you can see that for a number of the children in the NICU, there was a request for a specific indication-based analysis, because these children obviously had underlying conditions that could have been genetic. And so these are our results. So we had 11% found what we call a monogenic disease risk finding. And this is a list of what all of those conditions are, and if there was evidence or not, phenotypic evidence. And just of note, there was one child who did have biotinidase deficiency, which is also would have been detected, or was, well, it was detected, and then was detected and then repeated, and they didn't see it. So it was kind of a borderline case in terms of the newborn screening. But anyway, it was one of the conditions on the newborn screen. And this is just to say that in a sense, everything was actionable, just in terms of what people did about it. So there was, in terms of the infants, they had consults, ongoing surveillance, imaging studies, and so forth. And then in terms of the families, a lot of the babies in which we found something, it was inherited from one of the parents. And so there was other things that were kind of done. So it, just to make the point that actionability is kind of a broad term, and in a sense, everything from our study ended up being actionable. And then in terms of parents' response to the study, basically you can see that there was no increase either among those in the control arm versus the sequencing arm, or among those who had a monogenic disease risk and those who didn't within the sequencing arm. There really was no increase in parental depression, anxiety, self-blame, or their perceptions of the child and their relationship. So we did not see any kind of negative psychosocial outcomes in the study. Of note, the BabySeq data is now in the LPDR, and this is just some screenshots from the longitudinal pediatric data resource. It shows on the right there some of the types of data we had. The children for the baby nursery didn't have a lot of, most of them were quite healthy, so there was not a lot of phenotypic data, but we certainly did collect demographics and some other kind of information. And again, this is all including the genetic data in the LPDR at the MBS TRN. So in summary, this was a comprehensive screening of healthy newborns, and 11% having an important finding. And we really saw no evidence that this upset parents or increased healthcare costs. However, almost all the parents who enrolled the study were non-Hispanic white. And so this is the kind of race distribution. So 76% were white, some were missing, but very few African-American or other ancestries. And in terms of Hispanic ethnicity, it was primarily non-Hispanic individuals who enrolled. And to give you just a comparison from, this is from the March of Dimes in terms of what the race and ethnic distribution of the United States is. So we were really not a very representative, did not have good representation from ancestry in this study. And so that led us to BabySeq 2. And BabySeq 2 is really designed to address this lack of diversity in the initial BabySeq project. And the concern is, of course, that there's distrust of research in genetics, oftentimes among underrepresented minorities. On the other hand, if genomic sequencing is to be offered as a component of newborn screening, it's really important that a broad range of ethnic and racial populations are engaged in the research to inform how we can do this. And so we've taken a little bit of a different approach in BabySeq 2. So instead of enrolling immediately after birth, we are enrolling in community health centers that serve underrepresented minorities. And so the kind of concept is that in the Well Baby Nursery and the NICU at Boston Children's, they're both very diverse, ethnically, racially, very diverse centers, yet the people who chose to enroll tended to be white, highly educated, and non-Hispanic, and so, and high socioeconomic status. And so the idea is now to go to where people are and enroll from these community health centers. In addition, we've engaged a diverse community of parents to help understand their thoughts and concerns about genomic research and genomic screening of the child early in life. We've established a stakeholder board, which we're really calling a community advisory board, to help guide the study. And finally, we're are engaging individuals of diverse backgrounds as members of our research team. So this is an approach we really are kind of trying to take to address this lack of diversity. So this is this study is a U01. It's funded by NCATS, which is the Clinical Translational Research program at the NIH. And so there's 3 CTSA hubs as part of the study. The Brigham is a coordinating site, and then we're enrolling from Boston Children's at 2 community health centers, at Mount Sinai Hospital in New York City, and at the University of Alabama in Birmingham. And then we have a sequencing core, economic analysis at Harvard Pilgrim. Baylor's involved in doing the surveys, and then we have a healthcare provider education, which I'll mention in a moment, that's overseen by Hudson Alpha Institute for Biotechnology. So this is a very similar setup to BabySeq, the first BabySeq project. We are doing whole genome sequencing, not whole exome sequencing. The goal is to enroll 500 healthy infants and their pediatricians, again, focused on African-American Hispanic infants, on either standard pediatric care or that plus genomic sequencing, return of results, and then looking at medical, behavioral, and economic outcomes. And again, the goal is for over half of the cohort to be of self-reported African or Hispanic ancestry. So again, with the community engagement, as I mentioned, we have done a number of parent interviews prior to starting the study to understand their concerns, barriers to participation, type of information they would want, what kind of outcomes they would be interested in. And then we have this community advisory board with members for all sites, and they've actually really driven key decisions we've made in terms of enrollment. Even things like the consent form have been really been very active and important as we've developed this study, and will continue to be as we move forward, including partnering when writing up findings in publications with us. So one of the differences in this project is this healthcare provider enrollment and education. And so the concern when we kind of first submitted the study was brought up to us about a concern about healthcare providers receiving genetic information that they weren't prepared for, and particularly in a community-based setting where providers are obviously very busy. There's a lot of needs in the communities that they work with, and so adding one more thing could be perceived as really not good for providers. And so what we've done is developed with Hudson Alphas, who developed a SouthSeq genomics education program. We developed an education program and invited all providers at the sites who are caring for these infants to participate in this education intervention. And for those that do participate, those are the patients that they see are the ones who are going to enroll. And we now have, I think, 26 providers who have now participated in this education throughout the 3 sites. And one of the things that we've done to help incentivize providers is to offer American Board of Pediatrics Part 4 maintenance of certificate a credit for this, and that's something that's hard for pediatricians to get, and so that's been, I think, helpful for encouraging enrollment. So our study design is then, so again, not newborns, but as close to newborns as we can get in a community outpatient setting. So children 1 to 6 months of age, whose primary care provider completed this education program, and then parents who are 18 years or older. We are doing the whole study in English and in Spanish, and we'll have individuals who speak Spanish, both in terms of helping enrolling as well as providing results back. So we're leveraging the frequent well baby visits to, again, decrease burden on the families. So baby visits at 1, 2, and 4 months of age. Parents complete the baseline survey and then are randomized. We've also decided, based on our community board, not to collect blood from infants who are in the control arm, but only from the arm getting the babies are getting sequenced. Since they have to do the baseline survey before enrollment, we don't think that that's going to affect any of our outcomes. The sequencing is done, it's again whole genome sequencing, so we can look at copy number variants that are have high penetrance. And it's done in a CLIA lab at the Broad and then analyzed at the Laboratory for Molecular Medicine. And again, because our family structures are not always traditional, so traditionally in genetics, we like to do trios, but a lot of the families that will be that we see in these clinics don't have the father isn't involved, or the grandmother is a legal guardian. And so to kind of get around that, we're not collecting up front trios, but instead, if we find something, we're offering families the opportunity to have 2 family members sequenced, and then we'll kind of figure out what the best way for that to work is. So for example, if there's a family with no father, but the mother and the grandmother is involved, we would potentially see if the variant was in the mother, and if so, test the grandmother. So we've tried to be much more flexible in how we think about doing genetics and family structures. And then we have our sequencing report, which will have risk for high onset and highly actionable adult onset conditions, carrier status, and which we found in the initial BabySeq, about 90% of individuals are a carrier for at least one condition, and then pharmacogenomics. And then in children who have a particular underlying condition, we would do a more in-depth indication-based analysis of that genome. And then we're doing surveys. These are just some of the domains. Again, looking at parent-child relationships, parent-partners relationship, and personal distress. Looking at surveys at baseline and immediately, and then 6 months post-disclosure, and again, both in English and in Spanish. And then we'll be assessing medical impact of genomic sequencing on the infant, the family members, and the providers. So this just kind of talks a little bit about the type of things we'll be doing. So reviewing the medical records, serving parents or talking to them to track symptoms or test results. And then really trying to determine whether the finding really reveals an unsuspected phenotype in the infant or the family, if it explains a family history of a condition, or if it prompts surveillance of the infant or family. And then from the providers, we'll be collecting feedback throughout the study. We have kind of what we call a virtual genome resource center, which basically means we're available kind of at any time for either healthcare providers, parents to contact us if they have any questions about the study. And then we will conduct interviews with the providers at each site towards the end of the study. And then this is just some of the economic outcomes that we're looking at as more exploratory. It's a small, it's not a large cohort, so it's a total of 500. So we still are looking at some attributable services, genomic services, and all costs, both in the child and in the parents. So this is kind of getting at, conceptually, kind of overall that, the way things kind of work now is that we have, for example, a child in the NICU, a phenotype, biomarkers, cascade testing. And the idea with BabySeq is kind of, to turn it over so that you start with the sequencing and then look at, is there family history, look at cascade testing and biomarkers and other phenotype, and kind of risk stratification and medical contextualization in the context of screening all babies to start out with, as opposed to just the ones that have a particular issue. And these genomic findings, we're likely to find, for us, we found 15%, 11% with monogenic risks, but essentially we're expecting to find monogenic risk, to identify those with carrier status, and potentially there could be a role in the future of looking more at polygenic analyses, which we're not doing at this point, but for example, polygenic risk scores to look for risk for other more common conditions. So kind of finally to kind of end is just thinking about how BabySeq informs the mission of the NBSTRN. So the NBSTRN has partnered with us throughout BabySeq in terms of our data collection, collecting common data elements, so what kind of information we're collecting, how we're collecting it, and then storing it for us. And I think that this project kind of advances the understanding of the use of genomics to screen, diagnose, and treat conditions and identified through through newborn screening, and lays a foundation for topics, for example, consent. How do you think about actionability of variants? How we think about analysis of genetic data from different racial groups, and how we use information like this over time. So I'll just end there. This is kind of our leadership team, again, at Boston Children's, at New York, and in Birmingham in terms of the 3 clinical sites, and then our funding. So again, this is primarily funded by the NCATS, the NICHD. Once we got funded, it also come in and contributed to some of our funding. We also had a small grant for the interviews from the Greenwald Foundation, and then some philanthropic partners. So I will end there, and I don't know, Amy, if you want to take questions or if you want to wait until till Wendy's talk.
I think we could take just a few questions if you don't mind, Dr. Holm. Thank you so much for a reminder of the great work of BabySeq and what you're doing with BabySeq too. That was really interesting. We have a question from Cynthia Ingram, and she wants to hear a little bit more about how highly actionable adult onset disorders are defined, reported, and followed up?
Yeah, so essentially, we've decided to return the adult onset conditions essentially as defined by the ACMG's um, kind of list of 73 conditions, of which there are essentially 2 that are adult onset only, which are the hereditary breast and ovarian cancer and Lynch syndrome. And so that's how we've defined those. We haven't kind of gone beyond that, but we've using the kind of benchmark of the ACMG list to make a decision about those condition. But that's a very good question.
And Ingrid, how do you follow those? Does it become part of their medical record? Is there, ongoing?
Yeah, so for what happens is that the babies, this all does go in their medical record. It's a research study that goes in their medical record. And so then, we talk to pediatricians. That's what kind of a resource center about, is to give guidance to pediatricians who are following children who have one of these conditions. In terms of the parents, that is something that doesn't go into their medical record, and we would turn to them, and then it's up to them. We would give advice on how to follow up on the findings, because a lot of what's found in the babies we also find in the parents, again, because most are dominant conditions.
Thank you. Thank you so much, Dr. Holman. I hope you can stay on to hear Dr. Chung's update on her efforts, and then maybe we can have a little question and answer session again. So thank you so much. So I want to remind everybody, Dr. Holman, Dr. Chung are both co-chairs of the steering committee for MBSTRN. So we're so grateful for their efforts to help guide us as we support newborn screening research. So with that, I have the pleasure to introduce Dr. Wendy Chung. Dr. Chung is a board certified medical geneticist with a wide range of experience and expertise. We most recently worked with Dr. Chung and her team on a 2-year effort to pilot newborn screening for Duchenne muscular dystrophy, along with Parent Project for Muscular Dystrophy. So we're really excited to hear from you today, Dr. Chung, on your new effort.
Thanks, Amy, and thanks, Ingrid, for making this easier by doing the introduction to BabySeq. So let me... Okay, hopefully you can see the full screen. So I'll say that I'm here representing a much larger group, and a shout out specifically to Michelle Kajana, Denise Kay, who I think are on the call as well. This is really a joint effort. As we started doing this, Amy referred to one newborn screen pilot that we've done in the past, but I'll say that we've done a series really of newborn screen pilots in New York, and it's been really fulfilling to me to be able to see how we can, from an equity point of view, make sure that we don't leave any baby behind. That's been a really, really strong, important thing to me as we've advanced this work. We started this work initially in 2016 with spinal muscular atrophy, and I won't rehearse this because it's been a while, but just to say that based on the data that we had and the evidence from that newborn screen in terms of feasibility and impact, this is now obviously something that we do across the country. And I don't know if I can get this to play or not, but this was actually our first baby identified in New York with, would have had type 1 SMA or 2 copies of the SMN2. And then she started on, at that time, it was a clinical trial with an ASO, and has done great in terms of her motor milestones. And from an equity point of view, I'm going to come back to this. She is a child that, just based on, I won't go into the details, but understanding her social situation and her parental situation, I am absolutely convinced would have been dead by the time she was 12 months because of the time that she would have been diagnosed based on her sort of situation. And so it's just incredible in terms of that impact. It got me thinking, though, at the time towards what else we could do. So if we could do, and to remind you that SMA was a molecularly based test, we did it on those newborn screening blood spots. And I'd had patients such as this patient, for instance. This patient actually came to me at the at the age of 8 years, beyond this picture, with a history of repeated epilepsy that was intractable, medically refractory, and intellectual disabilities. And when we made her diagnosis at 8 years, it was very bittersweet to me because, similar to what Ingrid was saying, we identified something very readily treatable, in this case by a dietary intervention. She was found to have a glucose transporter deficiency, and this could simply be treated in terms of a ketogenic diet rather than a carbohydrate-based diet. And so this is something Daryl DeVivo had described many years before, and we didn't have a great assay for that other than to be able to do it based on sequencing. And so it was that time that I started thinking about how could we do sequencing-based assays. I'm at Columbia University and in New York City in particular, and one of the things, as Ingrid was saying, is that it was also important to me to be able to say, I sometimes say, if you can do it in New York, you can do it anywhere. So to be able to take on that challenge, we have amazing diversity in terms of our community in every different dimension. It causes challenges for us that I'm realizing every day in terms of interpreting genomic information, but we like that challenge. We like to be challenged. And as we look about the diversity from an ancestral point of view, as I said, in New York and in the hospitals that we serve as part of Guardian, we do have that very, very rich diversity and a very high population density. So we can be able to touch more lives through a relatively small number of hospitals and centers. Similar to Ingrid, we actually started thinking about this study about 4 years ago and built a lot in terms of the experience that Ingrid and Robert Green had with BabySeq 1 and trying to learn from a lot of the lessons and talk to our community about really for them to design their study. We really considered it in that way. And as we did this, there were some things that we heard repeatedly and we paid very much attention to. One is that we didn't want to make this overly burdensome, similar to what Ingrid was saying in BabySeq 2. So we found as many ways as we could to be able to do that in terms of the workflow. So no additional sample was similar to what we've done for SMA, Duchenne muscular dystrophy, and now Guardian. So we take the same Guthrie card, the same heel stick that we do for our regular New York State newborn screen and be able to add on to that. And usually we have sufficient sample to be able to do that. Parents, again, with this age are completely comfortable with online consenting, so they appreciated that. And with this as a more complicated study than some of the others we'd done, they appreciated having some time to think about it. And so in the prior studies with SMA and DMD, we had done at the bedside. We always continue to do face-to-face at the bedside. And with this one being more complicated, we talked to the families and they made the suggestion that we start talking to them about this prenatally. So in the 3rd trimester, having some time where they could sort of process the information, think about it, talk to family members, talk to other doctors, talk to friends, family, whoever it might be, but be able to start processing that information. So that's in fact what we've been doing. We introduce that through the obstetricians. And then postpartum at the bedside in the hospital, our study staff go around to each potential participant and we really make this everyone in terms of being able to recruit almost everyone. We actually don't at this point go into our neonatal intensive care unit. We keep it, they have a lot of things going on. And so for right now, we've not been including them, although longer term, they certainly have requested it that they not be left behind either. As we do the consent, we then know that this is going to be an iterative process. We have whole genome sequencing as the backbone to do this. And currently we're doing 237 genes, but are in the process of considering I call it version 2 of this, and have taken community input again to be able to think about what to add or potentially if there's something we would take off. Our goal is to turn around the results in 3 to 6 weeks. We hope to eventually shave this down because we do want to see if we can get this down to a regular workflow that it would be for traditional newborn screening. So we're not there yet, and we appreciate it'll take us some time, but that is the ultimate goal. And of course, to be able to plug these kiddos in, as we do with all newborn screening, into the appropriate care. And we actually have specifically dedicated patient navigators, social workers, community healthcare workers to help help us in terms of then plugging those kiddos in to the resources that they need. So it's not just diagnose and adios, but it's really being able to get them on to the care. As we do this, we have, and anyone who'd like to see any of our study materials, they're posted on the website. Our list of genes that we currently include is posted on the website. So all of this is very transparent to be able to help anyone else do what they might want to do through their studies or to learn through what we've done. But we have I hope, very accessible video in English and Spanish that's using literally multiple iterations with community input in terms of getting the message crisp, clear, and to the point. As we did this, we did something that's a little bit different, and it is truly a research study, so it's an experiment in this. And I'll show you just in a second, but as we do this, we have two groups of conditions that parents can elect to opt into. If they decide to do the study, there's the core group of conditions, which is, I call news you can immediately use, which is similar to what Ingrid was saying, highly actionable conditions, that there's a medication, a dietary change that's highly efficacious. But we also heard from families that they wanted to know about things, in particular, things that might be associated with epilepsy or neurodevelopmental issues. If there were things that could be done, while they might not be curative, there would be things that would significantly potentially improve the outcome and for which there was treatment available. So I call those group 2 conditions. I'll get to those in a second. As we do this, we've taken individuals from our community, we've trained them in terms of being, they're not, and I will say they're not geneticists, they're people that are very caring people who care about their community. We've trained them in terms of becoming part of our study staff. And as we've done this, I think that's been very helpful because they use language that really resonates. They think in terms, they think of analogies in the same way that our study participants do. And I think about this because we're just coming back from the holidays. At times we do miss someone who's discharged prior to the time that we talk to them. So we have a way of being able to talk to them remotely at home that we actually developed as part of our COVID protocol. So COVID came to be helpful after all. As we're doing this, as I said, right now, group 2 has about 100 conditions. Group 1 has about 150 conditions. And as I said, as we expand this, we'll probably be doubling those number of conditions within the next year or so. All of this is done in a CLIA clinical laboratory. Orthogonal confirmatory testing is done at the same time, and all of this is part of that turnaround time that we're trying to achieve. As we listened to families about what conditions to include, they were actually very prescriptive, and so we followed that very carefully. They wanted to have information that was relevant to young children. They defined that as age less than 5, and they wanted to be certain of those that what we were telling them was going to actually be something that would manifest. They didn't want a, slightly increased risk. They want to know, yes, this is really going to be something for my baby I have to worry about. So we chose a threshold of 90% for penetrance in thinking about this within that first 5 years. And there were many technical issues. We spent a lot of time in terms of validation of the assay. Again, for those of you who remember, we're in New York State, so we need to be able to go through in terms of the validation and being able to really make sure that our test was robust. And so we went through all of those processes using the dried blood spots and all of the methods we would use for DNA extraction from those tiny little dried blood spots. And as we do this, we do the orthogonal confirmation from the DNA from that, unless it might be something where we need more DNA specifically for something like a copy number variant. Within this, you may or may not have noticed, there are lots of partners within this. GeneDx /Semaphore is our diagnostic laboratory, and they've been great partners in terms of thinking very critically about some of the technical details in the genes or in the gene regions and making sure that we were able to actually diagnose these conditions. I will say there are certain conditions that we might have liked to have on the panel, but we've been somewhat conservative in terms of the things that are technically challenging. So congenital adrenal hyperplasia is certainly part of standard newborn screening. I don't feel confident that we can yet do this from the short read genome sequencing. So we've left this out for now. We do anticipate that as we get more experienced, and certainly we are still going back and looking at some of the data from the genomes that we have to see what we we will be able to do more robustly with time. As we're doing this, we do interpret the data without the benefit of traditional newborn screening. However, we do try and reconcile that before we talk to the families. So being able to see if we might have missed something, if there's something we see that traditional newborn screening didn't say. But again, we're trying to make sure that message back to the families is a coordinated, cohesive message that's coming, including traditional as well as now this additional newborn screening. So as we've done this, like I said, we've tried to do this and compare this to other studies, and in that we've had really robust results. For anyone who's interested, as I said, I'll point you to the website just in the interest of time in terms of the conditions that are included. There is overlap with traditional newborn screening. As I said, this was intentionally built in so we could see if we could diagnose some conditions that are done biochemically, as an example, molecularly, and or if this could help us in terms of decreasing the number of false positives. So if you think of this as a second built-in second tier test, what would the additional benefit for this be synergistically between biochemical as well as then genomically or molecularly based testing? So with this, as I said, group 1 conditions, very readily treatable, but a variety of ways in which they might be treated, including, for instance, hearing loss is something with cochlear implants or other recognition to help early language development. And then the group 2 conditions, as I said, many of them associated with epilepsy. I will say that one of the ways to be able to confirm the diagnosis, Ingrid alluded to this a little bit, especially for these group 2 conditions where you may not see physiological evidence of a seizure immediately in the first few weeks of life or any sort of developmental issues. In that case, parental testing becomes critical because many of those variants for the group 2 conditions are de novo. So we decided within the confines of this study, covered within the cost of the study, would be included parental testing for this for either group 1 or group 2. If we needed to do orthogonal functional testing as well, that would be included. We wanted to get to the point of resolution by the end of the study about whether or not this was in fact something to be concerned about or not. And then clinical care would take on after the study result was definitive. We have, as Ingrid alluded to this as well with BabySeq 2, we've tried to be really in the side of specificity, in particular for group 2 conditions, that is that families didn't want to hear about uncertain results or variants of uncertain significance. For many of the group 1 conditions, though, that are recessively inherited, where it takes 2 variants, we did agree that we would take a combination of either path likely path compound hets or a path likely path in trans or possibly in trans with a variant of uncertain significance that favored being pathogenic, where there was an orthogonal way of being able to resolve this, help us basically both sensitivity and specificity and optimizing the 2 of those together. And this is something that over time, I think we'll get better at being able to decide where that threshold is. Similar to Ingrid, as Ingrid had described, all the results go into the EHR. We're setting these up so we have direct data feeds because there's a lot of data that's going back and forth and we want to make sure we're not making mistakes. In the early days, in our first 1,000 at least, what we're doing is disclosing all of these by calling each of the parents and being able to talk them through either positive or negative results, make sure they understand that information, also giving them to this in terms of an individual result, and then of course, placing this both in the newborn screening system of Neometrics as well as in our local hospital's electronic medical record. So it's following the same workflow, as I said, that traditional newborn screening is to make sure that all of this would work out the way we think it should. For positive results, yours truly calls out positive results with the assistance of Carrie Koval, one of my senior genetic counselors. As we're doing this, we get the babies in right away, similar to traditional newborn screening. We have a whole library of action sheets now for these conditions, similar to what we do with traditional newborn screening. Happy to share any of those. And as I said, as we do that, we bring the babies back in for any type of additional testing that's needed and have a whole team, nurse practitioner, as I said, physicians, genetic counselors to be able to help with all of that. Similar to what Ingrid is saying, of course, we're interested in terms of understanding the long-term impact in this and really having this as a pilot study that will help, I hope, in terms of providing data for the RUS for additional nominations in the future. So as we're thinking about this, I'm conscious of time and I want to get to some of our results. As we've been doing this, we similarly want to look at the psychosocial impact, the economic impact, the clinical outcomes, and we'll be following the babies going forward, as well as with a series of surveys to the parents to understand how they've been doing with all of this. And this would be for both a representative group of negatives, positives, as well as ones that started out as being possible, but were adjudicated not to be positive, so false positives, if you will. The exciting part for me, and this is now how are we actually doing within this? We've been doing this for, let me see, I guess about the last 4.5 months or so. And as we've done this, we're close to our first 1,000 babies who are coming through and consented. We're not quite there yet. As we've been doing this and offering it, we found that of the parents that we offer this to through the protocol that I suggested, it's about 74–75% of parents who are deciding to do the study. So it's the majority of individuals, but not everyone. And I actually think that's a healthy balance in terms of being able to understand the study. And there's some people that have issues, sensitivities in terms of privacy or concerns about genetic studies in general, or concerns about research of any sort. And I absolutely respect that. So I'm not surprised that not everyone wants to do this, but on the other hand, I feel like we've got the balance of what families were asking for based on the fact that the majority of families are doing this. In terms of this opportunity to do either everything that I described, both group 1 and group 2, or just the core group of conditions, the majority of parents, 86%, are saying, give me everything. If I'm going to do this, I'm all in. And I think that's interesting to me in terms of, and we've actually written about this, and, are we ready to think about neurodevelopmental disorders in newborn screening? I don't know yet, but this is something that we're starting to think about. And as we're doing this, we realize that the method we're using to approach people, we're not quite 100% in terms of being able to get to every single baby. I will say we staff this 5 days a week rather than 7 days a week. That's just what's sort of feasible for us right now. And so we are missing a few babies, and we will have to think about ways of making sure we don't leave anyone behind. As we're doing this, as I said, for the ones so far that we've had results, we're running about 8% or so that are positive in some way, but we're learning a lot very quickly in terms of what those positives are. The majority of our positives are things that are, I don't think in a long term have huge sort of clinical consequences. G6PD is something that we're seeing quite frequently. It's an excellent condition. So, and within the ancestral groups we see in our community, it's more common. We're actually seeing quite a number of females, and even though it's X-linked, seeing quite a number of females because of the high prevalence. We're learning about CFTR variants. I feel like we've learned, I thought we had known a lot about CFTR variants for a long time, but we're still learning, there's still more. And in particular, realizing that variants that are 2 variants in this case where we didn't know phasing, I think we're learning that these are 2 variants in our community that are on the same haplotype. And so they're likely to be just carriers within this, but we needed to learn this. We need to figure this out. And so this first 1,000 is giving us the opportunity to find cases like this and to kind of do a pause and a data freeze and then figure out what our workflow will be after that. So we came into, as I said, realizing that this was iterative and we were going to learn. We've identified the standard things we do. So that's reassuring to us. Sickle cell disease from a baby that screened positive with congenital deafness, now knowing the genetic cause of that deafness. And then for these group 2 conditions, having diagnosed or identified a child with Dravet, a form of epilepsy. And then interestingly enough, a child with a CHD7 variant that we're now in the process of testing the parents. And I think appreciating which of these alleles are and are not pathogenic. And I won't be surprised if this is a false positive, so to speak, in terms of the screen. And so learning about, again, some of those things. Similar to Ingrid, some of our survey results, this is now a survey that's administered online for parents after they've consented to the test, but just to be able to show you that for the most part, the vast majority of people, I think, are really strongly agreeing with the purpose of doing the test being sort of that we've got it right in terms of how we're doing it. So a lot of endorsement. And of course, these are people that consented to the test. So keep that in mind. So most people did this to learn about their baby. That makes sense. But also I'll point out that many of them wanted to be able to help other babies. And that's something we hear repeatedly, is that even if this doesn't help my baby per se, it's something that'll help my next door neighbor or help someone within my community. And being able to do that and make sure that no community is left behind is something that's a really, really strong factor in our New York City group. Within this, an area that I think we've tried to message it correctly, and I think we still need to continue to explain this even better than we do, but there are people that go into this that are concerned their baby may have something. Our messaging to them is that we think in general, going into this, we thought that about 1 in 500 babies would have a true positive, like a true positive. And of course, you always worry for your baby, and I think that's what's reflected, but we hope to be able to reassure most people, of course, that that's not what we're seeing. Most people perfectly fine to have this in the medical records. A few, again, even though they enrolled into the study, a few people that had some hesitation about that. Most people are interested in research, genetic research specifically, and most people felt they knew enough about the study to participate in the study. And so even though our workflow, some people might, say, well, does that really work? It looks like for the people who are agreeing to do this, it is working for them. In terms of the time, they felt like they, again, for the most part, had enough time to make a decision, and that the time the study took itself was right, that it wasn't overly burdensome. There wasn't too much time that recruiters or coordinators were spending with them or going through the consenting process. So again, we feel like we've got, and we're looking at this data sort of within the pilot and feasibility, the first 1,000 of these babies, to kind of pause and see how we're doing. And so far, it looks like I said, that we're doing it about right, which is reassuring. So let me just end by saying it takes a big team of people, really talented colleagues that I'm so glad to be able to share with you, but it's really all their work that I'm sharing. So let me stop there.
Great. Thank you so much. And so now we'll go to our questions. And so starting with Ingrid. So one of our participants wants to know, what's your major takeaway from BabySeq 2? And where do you think genomics can go from here in terms of benefiting newborn screening?
Wow, that's a big question. So try to be kind of a short answer. I think that, I was kind of listening to Wendy and thinking about our study. I think that what we really we're looking for in BabySeq has been, do parents, what is the kind of impact of doing these kind of studies and this kind of, sequencing babies on parents? Because I think when we started BabySeq 2, which was in 2015 or 14, it was a long time ago, 10 years ago. There's a lot of concern about the risks to parents, the psychological risks, anxiety, worry, seeing your child as vulnerable, which is a lot of this kind of thing. And I think what BabySeq is really, one of the main things that we've shown is that there doesn't, at least in the population we enrolled, seem to be negative kind of effects on parents in terms of this kind of psychosocial effects. I think that's one of the things that we're going to show. And I think in the long run that we're hoping to show that, and again, I think similar to Wendy, we're hoping to show that you can do genome sequencing as part of newborn screening, find things that are important, that there's something that even if the actionability isn't traditionally actionable, at least from the family's perspective, there's something actionable about it. And so there's benefits to it, and yet we're not inducing excessive harms in terms of the healthcare system, the medical harms, psychosocial harms, or harms to the healthcare system. So for us, it's really showing that we can incorporate sequencing into newborn screening in a way that has kind of maximum benefits with really not a lot of risks.
I think that's so important, as we know, newborn screenings begins in public health, and it's a non-consented program. So I think both you and Wendy as researchers are helping us all sort of think through that implementation someday, potentially, of genomics and newborn screening. So building upon that, Ingrid, what was the thinking of the team in including babies up to the age of 6 months? What were you thinking about the
It had-
kinds of conditions?
I mean, for us, more had to do with our ability to enroll in the populations that we wanted to enroll. So in other words, when we tried, we had a different experience than Wendy did in terms of, as I showed you, a lot of people were not interested in enrolling in BabySeq. When we approached them, they were not interested in research when, the people who had kind of just had a baby. We had tried, for us, it wasn't as feasible to do prenatal enrollment because we don't have a limited population that goes from the prenatal setting to the newborn setting. And that might have helped. But anyway, so we did not have kind of people who who enrolled from the populations we wanted. And so the only way we could do it really was to go into the communities. And in order to give parents enough time to think about it and make a decision, it ends up being over a period of time. So if we approach them at their first visit and tell them about the study, we need to feel like we're needing to give them time to kind of think about it, at least some people. And then when they come back, they'll decide to enroll. So it's really there's less to do with what we're going to find than it has to do with enrolling families. And the things that I think it was mentioned here, neonatal diabetes. Yes, those people will have discovered before they enter our study. So we're not looking as much to making newborn diagnoses, but looking at the whole process of integrating sequencing and newborn screening and how does that work. And a lot of the things that we're kind of finding are risk for things that don't present in the newborn, but present later. And that was the same with BabySeq, the first BabySeq project. Even though we enrolled in newborns, a lot of the things that we found were things that present later.
That makes sense. And you're really trying to maximize enrollment in this research study.
Yes.
So turning to you, Dr. Chung, so Cynthia Ingram asks, have the PCPs had general advance information about Guardian so that they can be aware that some of their patients might be enrolled?
Sure. Cynthia, great question. And I'm sorry, I glossed over that one and then the next question as well. So we did an in-service on the obstetrical staff, as well as the neonatal staff in the hospital and the newborn nursery, as well as the pediatricians that all feed for those practices. I can't say that we got every single pediatrician of a baby that might have been born at the hospital because they could have come from here, there, or anywhere, but we did saturate the practices that usually are there. So they knew about this. We actually, for every positive, also call out the pediatrician in addition to the doctor or to the patient so that they, this is new to them and we wanted to be able to hold their hands as they're getting used to the process. And all of that's been going extremely well so far. Within this, I have to say, the pediatricians have really been quite thrilled about this, in part because they feel like it makes their life easier. They're less likely to miss a diagnosis. And to the point that's coming up, we have also the option for parents to have us retain the genomic data so that if a child becomes symptomatic later, it technically falls outside the Guardian study, but those data are available for a clinical reanalysis that can be quickly ordered and assessed on that child. And the pediatricians really like that opportunity, that again, from an equity point of view, it's less likely that their patients are getting left behind and that they can be more rapidly diagnosed if they're symptomatic.
Great. Well, thank you again, Dr. Chung and Dr. Holm, for this great tour into what you're doing on the research side to help us advance the use of genomics in the neonatal period. And we hope that we can have you back later this year to get an update on your important projects. With that, I want to conclude today's with a few announcements. So just a reminder that MBS TRN has a podcast called MBS Spotlight. Our most recent participant was Natisha Banam from Genetic Alliance and Expecting Health and Baby's First Test. So we hope that you can listen in to this episode and hear a little bit about Natasha's journey. And I know she's touched many of our lives and projects. A reminder that MBS TRN is hosting a virtual workshop as part of ASHG in late January. We'll remind everybody, but here's the link to sign up and participate in that workshop if you're interested. And we hope to see you all in person in Salt Lake City. We do have the Rodney Howell Symposium where we'll be talking again about genomics in the newborn period. And we hope that we can see you in person and join in. This is a monthly webinar, and Dr. Taylor on our team usually hosts these webinars. And in February, she'll be introducing you to Dr. Catherine Smith, who's doing some research in vision screening in the newborn period. So with that, we hope that you'll follow us on social media and reach out if you have any ideas or anything to share with us. Thank you so much, everybody. Have a great day.